Buenos días, buenas tardes, buenas noches a todos y a todas. Estamos por iniciar la actividad de hoy. Un momentito que estamos permitiendo a las personas que están en sala que ingresen. En un minuto iniciamos. Bienvenidos, colegas. Muy buenos días, buenas tardes y buenas
Welcome,
noches
colleagues.
para todos los
Good
participantes
morning,
que
good
están presentes en la
afternoon, good
mesa
evening for everybody from
y
any
también a
corner of
nuestras
the
personas que
Americas
nos están
and other
acompañando el día
countries
de
and
hoy.
other regions
Me permito
that are here with us
darles la
today.
bienvenida a este
I
seminario
offer you a warm
con
welcome to the
finalidad
seminar.
de
We know that we have
temas de salud,
authorities and representatives from
seguridad y
ministries of health,
necesidades
authorities and members
sociedades científicas
from
y comunitarias
associations or scientific
de toda la región,
societies of medicine and
especialistas en
family
la farmacia
community,
comunitaria,
groups of the
sanitarios
entire region,
médicos, ayudantes
specialists
sociales
and
y
professionals from
científicos,
other
iniciadores de
specialties
servicios de salud,
that work at different
durante
levels
algunas
of the health
especialidades
services.
con
So,
cursos
in a very
universitarios,
special manner, we also
a los
extend
estudiantes de ciencias
a
de la
warm welcome to
educación,
the studies,
estudiantes
students of
académicos
science,
interesados en el
and
fortalecimiento
all the
de la
colleagues that
atención
are
primaria.
here interested in
Su
strengthening
presencia hoy
primary
es
health
parte de la
care.
respuesta que nuestra
Your
región
presence here is
necesita.
part of the response
Mi
that our
nombre es
region
Joana Díaz de
needs.
Valle,
And
yo
my
soy
name is
asesora
Joana
de
Diaz de
educación
Valle, and I am an advisor in
de
professional
recursos humanos para la
education
salud en la
and
Unidad de
human
Recursos
resources for
Humanos
health
para el
at
Desarrollo
the
de la
Human
Profesionalidad
Resources
en
Unit for
Enfermedades de la
Health
Salud, o
for
PAHE, y es un
PAHO.
honor para mí estar
And
con
it's an
ustedes
honor
acá
for
con
me
ustedes
to be here
apoyándoles
today
en
with
este
you,
seminario web. La
supporting
actividad
this
que hoy nos
webinar.
convoca
The activity that brings us
para
together
analizar la
here
formación y práctica
today
de
is
refuerzos
to
de salud en
analyze the
Unidas
training and
Americanas
practice
Centrales y
of the
Pacífico es un
workforce
evento
in family and community
coorganizado por la
medicine of the
ODS,
Americas. Is an event co-organized
World
by
American
PAHO,
Comunidad WONCA y
by
por
the
el
World, by
Laboratorio
WONCA,
de
and by the
PSS de la
Collaborating
Universidad
Center
de New
of
Mexico.
PAHO and WHO
Antes
of
de
New
comenzar,
Mexico University. And before we
permítanme
start,
darles un par
colleagues,
de indicaciones
let me
logísticas.
share with you
Este
a
seminario
couple of logistics indications. The
simultáneamente
seminar has
en
simultaneous
español,
interpretation in
así que
Spanish,
pueden
English,
seleccionar el
and
idioma que
Portuguese, so
ustedes
you may
deseen
select
utilizando el
the
botón
language of your
que ven
choice
a
by
la parte
using the
inferior de su
interpretation
pantalla.
icon in the
Según
bottom
permito a los
bar of your
participantes
screens.
presentar
The
sus
microphones of the
presentaciones.
participants are going to be
Por favor,
silenced during the
utilicen
presentations,
el
but
chat y
please,
la función de
we
Q&A
encourage you to
para
use
sus
the chat
preguntas.
and Q&A session for
Necesitamos
any question and
participantes
comment. We
activos
invite
si
you
queremos generar
to use them
conversación y
actively so that we
aprendizaje.
can generate exchanges
Esta
here in this
actividad está siendo
session.
grabada y estará
Our
disponible
activity
en
is being
Facebook
recorded and
y
will
en la
be
página de
available
Recursos Humanos
shortly at the portal
de
of
ustedes.
Human Resources for Health.
Colegas, iniciamos.
So, without further ado, colleagues,
Medicina
we
familiar
will
es un
start.
área
Family and
recomendada para
community
brindar el servicio de salud
medicine
más
is a
básico
strategic
para
pillar
cualquier
today
necesidad
for
de salud
strengthening
basada en
health
la atención
systems
primaria. Sistemas
based
más
on primary health care.
equitativos, más
They
resilientes
are
y
more
más
equitable, more
confiables.
resilient, and more
Y hoy les
centered
traemos
in
voces
people.
esenciales para
And
impulsar
today,
esta agenda en la región.
we bring together essential
De un
voices
lado,
to
we have the
bring
owner,
this agenda to the
principal
region.
executive director of PAHO, Dr. Lou Valdez, who has been fundamental voice in advancing human resources for health in the Americas, and to whom we kindly invite to share her opening remarks. Dr. Lou Valdez, the floor is yours.
Johanna, thank you very much. Good afternoon, everyone. And on behalf of the Pan American Health Organization, it is truly a pleasure to welcome you to this regional webinar on family and community medicine training and practice in the Americas. We are also honored to join forces with the World Organization of Family Doctors, or WONCA, the Ibero and North American regions, and with the PAHO WHO Collaborating Center for Innovative Health, Workers' Education, Service, and Research Models at the University of New Mexico. I also warmly welcome colleagues from ministries of health, academic institutions, scientific societies, and the many specialists, residents, and students connected from across our region. Your participation signals a shared commitment to strengthening family and community medicine. Primary health care is the backbone of equitable, resilient, people-centered health systems. Strong interprofessional teams make this possible. And within those teams, family and community medicine is indispensable. Today's dialogue is anchored in new regional evidence. This study that you'll hear about, drawing on contributions from 23 countries, 19 professional associations, and nearly 300 specialists, offers for the first time a comprehensive and comparable view of how family and community medicine is trained and practiced across the Americas. The results are both encouraging and challenging. Many countries have well-established training pathways, yet access to continuous professional development remains uneven, particularly in Central America and the Latin Caribbean. Working conditions also demand attention, as only 1/3 of countries have policies to support the well-being and retention of this workforce. And persistent inequities in distribution continue to limit care, especially in rural and underserved communities. Now, these issues are not new, but the evidence sharpens our understanding and reinforces the urgency to act. Through the Health Workforce Policy 2030, PAHO and its member states have charted a clear course to strengthen governance, expand team-based training, improve working conditions, and promote a more equitable distribution of health workers. This is not optional. Rather, it is foundational to building resilient health systems. Family and community medicine embodies this vision. It is comprehensive, continuous, and rooted in the realities of the people and communities, the essence of primary health care. Today is not only about presenting findings, however, it's also about advancing a collective agenda for countries to strengthen policy and expand training opportunities, for academic institutions to innovate and adapt, and for health systems to better support and value primary healthcare teams. I hope this discussion reinforces a shared conviction that investing in family and community medicine means stronger, more resilient health systems for the Americas and more effective and committed health professionals. So we hope you enjoy our webinar. We think you will. And so back over to you, Johanna. Thank you.
Thank you very much, Dr. Valdez, for your words, which also reaffirm PAHO's commitment to this issue so central for the health of the Americas. A continuación, colegas, nos acompaña también la presidenta de la
Now, colleagues, we have the president of the World Organization of Family Physicians, WONCA, a global voice that reminds us that this challenge transcends borders. Dr. Martinez Bianchi, the floor is yours. Thank you so much, Johanna. Esteemed colleagues and representatives of PAHO Marilu Valdez, thank you so much for your kind remarks, ministries of health, academic institutions, and colleagues of family and community medicine. It's a real honor to be with you today. I am right now in the World Conference of Rural Health in New Zealand, but it's important to be here in representation of WONCA in such an important dialogue on training and practice of the workforce in family and community medicine in the Americas. For me, this meeting reflects a fundamental truth. Family and community medicine is not just a specialty, it's a strategic pillar to build stronger, more resilient, and more equitable health systems. Along the Americas, we see important advances, but also very persistent gaps. While training programs have grown and the specialty has earned recognition, there's still a great heterogeneity on how family medicine is integrated, valued, and supported within the health systems. And this is not just a matter of human resources, it's a matter of access, equity, and trust. At WONCA, we represent a global network of organizations of family medicine, academic institutions, and professional institutions at the front line committed to strengthening primary health care. And in the Americas, this is coordinated through two regional solids, WONCA SIMS and WONCA North America, and these regions reflect the diversity, the complexity, and the wealth of community and family medicine in our continent, from rural communities in the Andes to large urban centers, from small insular states to large scale federal systems. But I don't want to keep going without recognizing the great work of two exceptional leaders, Dr. Dora Bernal, president of WONCA Ibero-Americana, family medicine physician in Colombia, and Dr. Tania Whitby-Best, president of WONCA North America, who practices in Barbados as medical official and head of medical services in the West Indies. And the leadership of these two women and many that you're going to hear about today reflect the strength of our regions, the essential role of family physicians in advancing in health for all. Family medicine is in a unique position to respond to the most urgent challenges of our systems, and these most urgent challenges are fragmentation, inequity, uncovered needs or unmet needs, and the lack of funds for the necessary training of family physicians. We provide continuous care, person focused, and also focused on family and community. And with this, we improve the coordination, quality, and results at the primary care level. But to be able to fully reach this potential, we must act, we must invest in training aligned with the needs of each community. We need to create working environments that retain our workforce. We need to guarantee the recognition and regulation and fair working conditions, and we need to strengthen the collaboration among sectors and institutions and countries. That's why this regional study and this dialogue are so important, and I hope this is the first of many more dialogues to advance in this field, because the future of our health systems doesn't only depend on how many professionals we train, but how we support them, how do we value them, and how do we integrate them into systems designed to serve people, families, and communities. WONCA reaffirms its commitment to keep working together with PAHO and the ministries of health, universities, and professional organizations in the entire region of the Americas. Thank you so much for your leadership, for your collaboration, and for your commitment to strengthening family and community medicine as one medicine for all, and through this, to the health of our communities. Thank you so much. Thank you so much, Dr. Martinez Bianchi. Your global perspective locates us where it corresponds in a regional conversation, but with a worldwide projection. That's excellent.
We are joined by the representative of the University of New Mexico and the PAHO Collaborating Center for Innovative Models of Education, Service, and Research, Dr. Arthur Kaufman. Thank you so much for being here with us today. The floor is yours.
Thank you so much, Johanna, and to PAHO for creating this space to discuss family community medicine, whose need is so vital to truly address community health in this time of damaging cuts to WHO programs and international turmoil. In a world of growing disparities, socioeconomic instability, and the devastation of climate change, mass migration, and refugee surges, family and community medicine has an ever more important role to play. WHO describes social determinants of health as having a far greater impact on health than the medical care systems. But since adverse social determinants takes place in the community, it is family and community medicine so closely linked to its community served that has the interest, orientation, and capacity to incorporate screening and addressing social determinants at its origin. But barriers to realizing the potential of family community medicine is well summarized in the PAHO WONCA UNM study, Workforce Training and Practice in Family and Community Medicine in the Americas. And this runs the gamut from low recognition to poor resource support to low income, and finally to physician burnout. However, an innovative family and community medicine service and education model appealing to multi-sector stakeholders, governments, and funders is emerging in different countries. It's a model that's driven by communities' health priorities. One, expanding family and community medicine's capacity to address adverse social determinants by incorporating, for example, community health workers into family practice. In fact, in New Mexico, we learned this model from the Pan American Health Organization, WHO, linked partner institutions in South America and in Africa. And finally, family and community medicine can be a bridge between community needs and the whole university that trains family doctors. When we address social determinants, our most needed communities can tap into those resources. Just for example, they can tap into engineering for expertise in rural transportation. They can tap into architecture to address housing needs of the homeless. And education can help improve the graduation rates of underserved youth, which has such a profound effect on health. All university sectors have expertise that can contribute to the broad health and social needs of communities, led by family and community medicine, to make a far greater impact on community health. So thank you very much.
Thank you very much, Dr. Kaufman. This interinstitutional partnership is precisely what has made the study we present today possible. So thank you very much. Colegas, con esta base llegamos entonces a la sesión de...
Colleagues, with this, we get to the heart of today's session in 2024. PAHO and its partners did this regional comprehensive study, the first one in its type, and with this type of scope that examines how family medicine is trained and practiced in 23 countries in the Americas, with revealing and urgent findings that are actionable. So I now have the honor of inviting Dr. Benjamin Puertas, head of the Unit of Human Resources for Health for PAHO and one of the authors of the study that we're presenting that has been published in the Pan American Journal of Public Health, to show us the main findings of this regional evidence. We're going to be giving you the link on the chat so you can access. Dr. Puertas, thank you. Welcome. The floor is yours.
Welcome to everyone. My greetings to my colleagues who were in the panel and also those who are going to discuss later on during the presentations. I also want to express my my gratitude to all the co-authors and the institutions that were involved in this study. This is the Pan American Health Organization, WONCA, and University of New Mexico. I'm going to switch to Spanish for the presentation, and just to make sure that you all can see the presentation now that I'm sharing. Muy bien. Como un contexto.
Okay, so as a context, I want to start by pointing out that there's more than 11 million healthcare workers in our region, but that they're facing a global crisis from the labor point of view, education, availability, distribution, financial investment, working conditions, gender, and of course, a gap that by 2030 could reach 600,000 healthcare professionals, or even more, reaching 2 million. And you can see the graph on the right, where, of course, the component in nursing is the broadest or the largest one with this gap. And sharing with you on how we're doing as a region in terms of density of health personnel with a group of countries that's 12 that represents a third of the countries approximately that have a density below that gold standard established by WHO of 44.5 by 10,000 for every 10,000 inhabitants. But there's inequities in distribution, as our colleagues were mentioning in the opening remarks. There's also inequities in regards to age. For example, here you can see that there's already a percentage of physicians over 55 years of age and are getting close to retirement. And in certain countries, there is no generational relay. This also contributes to these gaps. From the perspective of family and community medicine, Viviana already explained very clearly what the concept is of a discipline that's not just academic, it's clinical, that they provide continuous, comprehensive, and coordinated care centered in family and community along the life course, and that considers biological, psychological, socioeconomic, cultural, and spiritual parameters. And from the perspective of what our policy, and I say our because it's the 2030 staff policy for healthcare workers, there is a specific line that talks about strengthening the interpersonal health service teams, and it talks about strengthening training and integration of interprofessional teams in the networks that are integrated by the health services based in primary health care. And here is where family medicine plays its very important role. The adoption of family and community medicine has been established that is linked to a greater effectiveness in the implementation of primary healthcare strategies. And I want to mention a very important moment that happened in the past year, where it's the creation of the Alliance for Early Intervention or for Primary Healthcare by three partners: PAHO, the World Bank, and the IDB. And they want to do this through investment, innovation, and implementation. And this is in a very important context. And with this, I now go to talk about the study in training and practice of medicine, family and community medicine personnel. Why this study? Because there's over 30 years of practice established in the region that in China, for example, it's 4 years, and in Mexico, it's over 7 decades. And family medicine is key for health systems based on primary health care. There's very little regional evidence, as Dr. Diaz was saying, about the status of training and practice in our region, and also gaps in labor conditions that have been reported by the countries. Therefore, the objective of the study is to analyze the current status of training and practice of family and community medicine and try to identify gaps and opportunities to look for strategic actions and implement them to strengthen the workforce. Very quickly, the methodology is about an observational design, analytical, and transversal in the region of the Americas. And this was done in 2024. And we covered 23 countries in our region with 19 professional associations that represent the whole of the associations recognized in the continent, and when 291 specialists in community and family medicine that have been surveyed. The survey had two moments. One for associations and the other one for specialists. One for associations had 22 items that were analyzed and that cover these variables: training, certification, continuous education, labor conditions, and well-being policies. And in the specialist survey covers 12 items, among them that go around individual experiences in the practice, access to continuous education, workload, and conditions of the professional practice. And here you can look at the participating countries. These are the associations, the 19 associations that I was mentioning, and the countries that participated, and the participating associations that, as you can see, involve the ones that we call the three subregions: Central America, South America and the
Los resultados. Desde la perspectiva de formación, en cuanto a modalidades de
The perspective
formación
of
y
training in
certificación,
terms of modalities of
vemos
training and
que el
certification,
68%
we
de
find that
países
68% of countries
alcanzan la
are able
formación de
to
medicina familiar a
reach
través de una
a family
especialización,
medicine training through a specialization
63%
program, with
vía programas de
63% being done
residencia
via
y el
resident programs, and
63% de los países
63.2
analizados
as countries that were
las
analyzed
dos formas, es decir, tanto
and
especialización o
in both ways,
residencia.
both
La media
specialization
dura en
and
promedio
resident.
2 a 4 años
The
para
me
formar
the
médicos familiares y
average
comunitarios,
to train this
pero la media está
family and
alrededor de
community
3
doctors has a
años.
median
En la
of
mayoría
about
de
3
países se
years,
requiere un
where
examen de
most
competencias,
countries
pero todavía
require
hay cerca de un
a
40%
competence
que
or a
no lo
skill
requieren
test,
así.
but there's still a 40% that does not
En cuanto a políticas de
require it.
acreditación
In
y
terms
en
of
base a lo que
accreditation
respondieron las
policies and
organizaciones
based on
profesionales,
what professional associations
tenemos
required,
políticas en 73%
we
de
have
países,
policies in a
esto es acreditación,
73% of
y el
countries
44%
and
es acreditación
accreditation, and
establecida por
44% of that
universidades
is done
y el
via universities
32% por
and a
asociaciones
33% by
profesionales.
professional
Y de
associations.
todos los países
So from
analizados,
all
igual
countries
63%
analyzed, there's
exige
a
que la
63%
formación
of them
sea
that demands that for
especializada.
that training to be specialized.
En base a este componente de
So
acreditación,
based on
en el
this
21 de los,
accreditation
de 21%
component,
de los países
21%
participantes se
of
requiere la
the
inscripción a
participant
una
countries
asociación
require
o
to
consejo de
be
certificación de manera
registered
obligatoria,
to a
y
specific
en
council as
42%
mandatory,
de los
and
países se requiere
42% of
certificación o
countries
renovación de
require
la inscripción
a
profesional cada
certification or
5 años.
renewal of the
Acá
professional
vamos a ver
certificate
y voy a
every
pasar
5 years.
rápidamente en el tema
And
de
here we're
formación,
going
cuál
to
fue la
go fairly
cobertura de
quick in terms of
contenido.
training. What
Hay
was the
contenidos que fueron
contents
valorados
coverage? There were
positivamente
contents
tanto
that
por
had
asociaciones
a
profesionales como
positive
especialistas.
score in professional
Usted pueden ver
associations
allí,
and
no va a leer,
specialists
pero
as
son
well.
temas
I'm not going
fundamentales.
to read that through, but these are
Medicina
fundamental
familiar, salud
topics in
pública,
family
enfermedades
medicine,
transmisibles,
public
curso de
health,
vida, etcétera.
communicable diseases,
Pero hay
course
diferencias,
of
¿no? En
life, etc.
Centroamérica, los
But there
contenidos
were
con menor
differences where
difusión,
in
sobre
Central
todo
America,
políticas de
those
salud,
contents that
salud
were the
mental,
most
medicina
seen
basada en la
were
evidencia, y en
healthcare
Sudamérica,
policies, mental
atención
health,
domiciliaria.
and
Pero
evidence-based
aquí miran que
medicine,
hay
while in
temas
South America it was
divergentes también.
different. And here we see
Mientras las asociaciones
divergent topics,
profesionales,
while
pues
in professional
todavía ellas hablaban de
associations,
que
where most of them
se recibe
were
formación en
talking about
investigación,
the
los
training and
especialistas que
research,
participaron no lo consideran
specialists
que es
that
tanto así.
participated
El
from it, they didn't feel
61%
it
en
was so much
Centroamérica
so,
menciona
with
haber
a
recibido
61%
y
of
el
them in Central America
67%
have said to
en
receive it, and a
Sudamérica.
67% of them in
En
South
cuanto a la
America.
formación, siguiendo
In
con las de
terms of
menor tendencia,
training
en todo
of
lo
the
que tiene que ver con
lowest
salud
trend,
ambiental,
here's what it has to
preparación
do
de
with
desastres,
environmental health,
sistemas de información de salud,
disaster preparedness, the use of
incorporación de
healthcare
telesalud,
information systems, and the incorporation of
fueron
telehealth.
señalados como los que
They
tienen
were
tendencia a
pointed
no
as
ser
those that
incluidos
had
en
the
la
trend not being
modalidad de
included
programas de
in the actual
formación.
curricular program of
En
this
cuanto a condiciones de
work
práctica,
trainings. In
el
terms of
46% de los
conditions of
países cuentan con
practice,
políticas de bienestar y
36% of the
retención,
countries had
y hubo en esto
policies
convergencia
of
entre lo que dijeron las
well-being and
asociaciones
retention,
versus lo que
and
dijeron
this
los
goes
especialistas.
crossing with what
Hubo
specialists
aspectos que fueron
said
valorados
and
negativamente en
professional
el sentido de que no son
associations said.
cubiertos o no están
They were
siendo
scored in the
considerados
sense that we're
en la
not being
práctica,
considered in the
y son
actual
actividades para
practice.
promover y
And
mantener
these
el
are
bienestar,
activities to
condiciones de trabajo,
promote and encourage
prevención de enfermedades ocupacionales,
well-being, working
oportunidades de
conditions,
desarrollo profesional,
occupational um,
programas de investigación, como ya vimos,
diseases,
y el
prevention,
desarrollo de
professional
políticas
development
públicas.
opportunities, and the
En
development
esto
of
del
public
desarrollo
policies.
profesional también hubo
In
diferencias
professional
entre lo que las
development, there were also
asociaciones
differences
profesionales
between what
señalaban.
professional
El
associations pointed
73%
at,
de los países
with a 73% of
disponen de educación
countries
continua para la
having a
formación de
continuous
médicos familiares y
education
comunitarios,
available
pero no
for
así
community and family
en
physicians,
especialistas
but
que
not so
hablaban de
for
porcentajes
specialists
menores.
that talked about lower
Igual con el
percentages.
uso de protocolos clínicos,
Same thing with the clinical protocol
usualmente
use.
apenas
There were differences, with
45% de
South
los
America being
especialistas
only
señalaban que utilizaban
46% of
protocolos clínicos
specialties
y miran la diferencia
used in clinical
con lo que
protocols,
señalaban
and look at the
las
difference with what
asociaciones.
the
En
association said.
investigación ya vimos que hay
In research, we've already
deficiencias
said
que fueron
that there
notadas
were
en-
deficiencies
en- por
pointed
parte de los
at
especialistas,
by
igual con políticas
specialists
públicas.
as well with
Y esto nos lleva a los
public
retos.
policies.
Which leads us to the challenges. In terms of the challenges we've identified, there was a coherence between what the associations and the specialties what they expressed, a lack of knowledge or a lack evaluation of the specialty, and also the not so adequate working conditions, remuneration that they found to be incompatible with the specialist physician, and the inadequate infrastructure and insufficient resources, and a workload that was just so much and it was too saturated. In terms of the gaps that we've identified, coming close now to the conclusions, and then the emerging topics that are evidently absent of many programs, the variability among countries, the need for looking at these topics that are emerging constantly, but the need to harmonize the regional competences as well. The continuous education with more than half specialists without the proper access, and insufficient access in Central America, the Caribbean, and Mexico, and the absence of regional platforms that are sustainable. The working conditions show that 7 out of 19 countries have only a few well-being policies and retention, the scarcity of the education and vocational training. This brings us to some recommendations that are necessary from the very structured baselines, and that is related to the development of public policies and the strengthening of primary care, governance, funding, infrastructure, in terms of the professional setting, the honorable working conditions, etc., in terms of service rendering and the person-centered care in a collaboration practice. Here's the importance of having interprofessional and multidisciplinary teams where we definitely need to have the core of family and community medicine, the confidence of the community, the social acceptance, and the development of skills based on competences and standards of training, postgraduate trainings as well. And with that, I bring the recommendations that come from this study. Part of number one is the recognition and the valuing that specialists as a strategic specialty, to encourage quality of training, incorporating emerging topics in the programs. We talked about digital health, environmental challenges, interculturality, to establish and develop regional platforms for continuous education. PAHO has the virtual campus with more than 5 million users and participants, for instance, to be able to implement working conditions and to implement then the national policies and welfare and well-being, the retention and incentives, responses from the ministries as a coordination with the multi-sectorial action, and training and information systems to strengthen data production and the working power and the workforce for decision making. And with that, I finish with this key message, with this more than 3 decades of study, the continuous assessment. It doesn't mean that this specialty is not going to face specific challenges. It demands investment in strategic conditions, all of them based in APS. And with that, I finish my presentation as summary, actually, because the study is actually a whole lot deeper and has a whole lot more detail. But this gives us like a taste of it to see what are those serious challenges that we face in PAHO, together with the colleagues of WONCA and academic institutions could address. Thank you so much. And now I leave it over to the person in charge. Thank you, Dr. Puertas. The info you give us is really relevant. And as you said, this is only part of the information that is the most to highlight from the study. And I just want to invite you all, colleagues, to read the publication. I am posting the link on the chat so you can see it. Now, I would like to bring up a very important question to provoke our conversation. What is it that we are doing, and what can we better to integrate community and family medicine in our healthcare systems? And that is, of course, to impact the perspective of those that create public policies and are in charge of decision making. To start with this perspective and practice of evidence to action. This is a panel that is led by Dr. Jacqueline Ponzo from WONCA in Uruguay. So, Dr. Ponzo, you have 25 minutes to take care of this panel. I want to thank to all our panel members for being here. So let us please remain within our time limit so we can continue with the rest of the activity. Thank you very much. Welcome, Dr. Ponzo. Thank you, Johanna. And good afternoon, everybody. It is really gratifying to be able to share this little milestones and this information that we have concerning a reality that we all know that is quite complex, but we also feel that this is going to be very useful to continue in the construction of healthcare systems that actually do respond to needs the better and that adapt to the characteristics of our specific population in our region, but also globally. So I'm going to try not to take up so much time. We have three panel members who are going to share with us about their perspective in our region with three very interesting and different countries in each of the subregions, from Brazil all the way from the south to the Andean countries in Peru and Central America in Costa Rica. So I'm going to now check if we have Juan Carlos Esquivel with us. I see you. I can see you, Juan Carlos. Okay, so I'm going to go with Juan Carlos Esquivel first. He's the executive director of the Strategic Development Center of Healthcare Information and Social Security, Bolsendis, in Costa Rica. And he's going to share with us about this perspective from the institutional part of it, the policies made, challenges, progress, and also, why not, frustration to incorporate the family and community medicine within healthcare systems. Thank you, Juan Carlos. Good morning. Thank you very much, Jacqueline. And I want to thank all of the organizers of this webinar, to PAHO and the Global Association of Family and Community Medicine. The results that Dr. Benjamin Puertas has shown are quite interesting based on that study that was conducted. It's certainly an important input for decision making. For instance, for the institution that I represent the Costa Rican Social Security Department, and the center that I am in charge of directing has to do with the training, teaching, and research, among other tasks, but in this case of medical specialties, and one of them is, as we've said, community and family medicine. As a short background, I must tell you that in Costa Rica, the Social Security Department is the only public agency that provides services for public health and pensions. With that in mind, the Social Security Department focuses its service rendering model in three levels, of like in tiers of first, second, and third level of care, with the third one being the more specialized. Community and family medicine as a specialty is one of those that are like the most novelty ones that started back in the 80s here in the country. And from the very beginning, it started to articulate pretty good in our model of service, healthcare services rendering. And I feel that it has been one of those pillars that has come to reinforce that service from the Social Security Department. Certainly, the perspective in training, including the patient within all of its of their social context, brings a completely different connotation to all other 56 specialties that we manage in the training with different universities. Within that model of service rendering, the approach to community and family medicine is then going to strengthen the first level of attention, which is promotion and prevention of healthcare and prevention of diseases in that scenario. And today, this is very important when facing the challenges that any other agency would have, which has to do with populations aging, chronic non-communicable diseases in the uproar. And since we believe in the strengthening of that first level of care with community and family medicine to try and desaturate more complexity levels, like the third level of care, while bringing an impact in the funding of healthcare services, which is also an important burden in our system. As I have been saying, this is actually a specialty that has brought a lot of value in terms of development. We have faced plenty challenges and difficulties, but it is a specialty different to all others that has that vision of care patient of caring for the patient in a comprehensive way from the community and even at the working environment of our patients. The third level of care in Costa Rica is then strengthened because we bring that care to the community and to the working environment where we have our physicians that are specialists in this kind of medicine for screenings that are being done to school children, household visits, and to look at patients that may not be able to go to an actual care center. So what this provides is new programs the institution has been bringing up. One example is for third level of care, for instance, we've encouraged the creation of the walking hospitals, which creates like a synergy that is quite strong between all of the stakeholders in this very complex level of care, with showing a greater desaturation of hospitals, so that through this home care visits with the specialties visiting patients according to their disease. Our country is small. We're only 5 million people, but we have a livelihood of about 80 years, which makes us very compatible with developed countries. So I think that throughout the last decades, the country has been able to control most of communicable diseases that historically have affected Latin America, which is also helping us see the strengthening in the approach of the epidemiological care. And in our structure of the model in Costa Rica shows the institutional result with family or community and family medicine to be quite advantageous. It is a process which, as I said, is being done together with the universities, where the Social Security Department is this agency that creates agreements with universities in the training of community and family medicine, mostly in the first level of care, but also in third levels of care, as I mentioned earlier. So that's like a global context of how we're organized. We've been organizing from the community to the hospitals. So, of course, community and family medicine brings in an added value that is very important. Thank you, Juan Carlos. There's so much that needs to be said. but we have to move quickly to gather the Peruvian experience. So I'm going to introduce to you Maria Sofia Cubas Puentes. She is a dear colleague that is a researcher in the Peruvian University of Heredia, and she's specialized in family medicine. And at the regional level, she was the president of the Peruvian Association of Community and Family Medicine, and up to very recently, the coordinator of the regional research network of WONCA. So, good afternoon, Sophia. This is your space. Thank you. Good afternoon, everybody. It's wonderful to hear so many colleagues that we've met in family medicine all these years. So thank you, Jacqueline, for the invitation and the organization. So I wanted to address a little of something that probably the study has already seen, but are more specific to Peru. So I just want to bring you into the context. Probably many of you have heard that for the last 10 years, Peru has had a lot of political turmoil, probably just like many other countries, but in our region is specific because we've changed like 3 times our president. Sunday, we have elections. We have 35 candidates going for it. And something that is very common in what's being said by these candidates is that several governmental programs are trying to unify the healthcare system, which we do have been quite segmented. Sebastián Salar Bondi said, "My country, I now know, is a bittersweet feel, an intense passion. It's a lot of mixtures, mates that have a lot of touches, that have wonderful mountains. It's a heart that has been hammered strongly in a forest where the light comes through the trees and the dead mountains. Sometimes writers and poets bring better to life what is actually happening in our country and a healthcare system. This year, we have been working for 37 years in the training of physicians in Peru with 70 work positions and in a lot of important universities, focusing mostly in Lima. And in 2003, we only have one a job position with family medicine. And there were many changes years ago with 322 work positions in 21 universities, 14 regions of the country. And at that point, we had already 400 graduates. Yesterday, I asked the medical college to give us some information on those that we have active in family medicine. And right now, we have over 1,700 family physicians. At the beginning, they were called comprehensive general physicians. And then it was called community and family medicine. And with the 37 years of training, we had then that number. But if you notice, in Peru, we have 98,000 active graduated physicians and 62,000 general physicians that had not done this specialty. So in family medicine, we're less than 2% the total of active physicians. And so we have about 3% of general physicians. We're very few. And that makes us reflect that we have to do something else for this to change. So I want to show you a little bit of what we've done. This is something that has moved the training in several programs on how to train these experts in family medicine. This is a paper that maybe many of you already know about. How to have all these roles addressed with so much competence. And I know that for the last years, we have worked a lot to strengthen the training. We have done many studies. We've conducted many analysis with colleagues from Chile, and we worked with this one where we asked the teachers if they had been trained, how was their link and liaison with the universities. And so, for instance, we found that only 13.6% of them had had an actual training as teachers, with all of them working more than 10 hours for it amongst those that we had contacted for this study, with a small sample, because we were looking for those that were being trained as teacher. Many of them did not have a formal relationship. So this is a landscape that has changed after COVID, because many universities have worked with the latest training of the last year, which in Latin America we call it internship to training in the first level, with at least a quarter of that rotation. So many of those working in the first level start being tutors, but they're not always family doctors. And quite recently, from our research center, we published this paper on the perception of students of medicine with a sample of 418 students about their perspective to work in primary healthcare. Only 2.2% of students from both university were expecting or wanted to work in primary healthcare, and many of them expressed that they were seeing that first level of care as a temporary space before actually going to hospital work, and that the hospital would offer more interesting cases and better income.
So in Peru, we have advanced these years. I think that more and more, different than when I was getting trained, family medicine is more in the political discourse. Actually, in the past 5 years, there's been several regulations to organize integrated health networks in Peru, and many of the training documents mention family physicians. However, we still need spots for all health centers for family physicians in the States. Many times they say, well, there's not enough, but it's like the story of the egg or the chicken. So if there's no spots, even if students have more exposure to family medicine, they don't see the space as a space where they could work. There's a lot of universities that in the past few years have started to have undergrad training in family medicine. The university where I work, which is Cayetano Heredia, we have the sixth year rotation in family medicine, and there are several universities that are starting to have them, or tutor family physicians. There's more spots for specialists in family medicine being created, and there's been also a reform in mental community health that in the past 10 years in Peru, and there's almost 300 centers for community mental health in the country. Many are led by family and community physicians. The residency programs, there are more that have tutors, because when the residency programs were massified, many didn't have tutors that were family physicians. And I think that the group has had cohesion, a group of specialists in the country that learn to love and fight for the specialty. There's more and more permanent activities. There's a lot of activities in young physicians in Huanacay, in the Peruvian Association of Family Medicine. They start participating more in courses and conferences, and I think they're doing this more and more and getting nurtured from this community. Like, for example, the WONCA conferences that make us all feel recharged to be able to do more things for family medicine. There's also a lot of family physicians positioned at different management levels. Actually, this reform to the comprehensive health networks have a family physician. They've been working on standards for chronic diseases, also on how integrated health networks are going to be created in teaching and in research. Sorry, just one thing. On behalf of the translators, you are going very, very fast. We're not able to interpret everything that you're trying to say. Thank you so much. I know we're running late, but we please ask you for this. Thank you. I was saying that there's more physicians positioned at different levels and also in teaching. And I was saying that for us, a milestone um, it's, for us has been to create a research center in primary healthcare that has been working for 4 years and that starts doing more relevant research for our region, and also so that young students and residents can take primary healthcare as their line. I always come back to McQueenie. He's not Latin American, he's Canadian. And I think that he always reminds us the importance of being different, because that means that we're capable of leading change. And he was always saying that we have to reflect on what we do, if we're doing things right or not, if it serves the country, how we're doing it, and what we are researching and what we are publishing. So I think that the situation in Peru might probably change. Hopefully, with the change in office, there might be new viewpoints towards strengthening primary health and giving the opportunity for more family physicians to be able to exercise close to their communities and have a better practice and help build a better health system. And Julio Roman Rivero said that we have to be the eternal foreigner and the eternal apprentice, and that's the way of being happy. So maybe all of these challenges that we have in the country still help us to keep thinking about how we could be better family physicians and how we make the system work better from where we're at. From research, from teaching, from activism also. So I close with that. Thank you so much. Thank you so much, Sophia. This is a sample of intensity and complexity that this has in our country's situation of Peru. We are going to hand the floor to the last member of the panel, Dr. Fabiano Narvaez, from Brazil. Fabiano is the preceptor of the residency program of the Federal University of Minas Gerais. He's also a professor of family medicine in the undergrad level, and he is currently the president of the Brazilian Society of Family and Community Medicine. In Brazil is one of the countries that, through different strategies, has been able to have a significant increase of the number of specialists, both in absolute numbers as well as the integration to the national system. So we are going to be listening closely to the summary presented by Fabiano on Brazil's experience. Thank you so much, Fabiano. Thank you so much, Jacqueline. I want to thank Johanna and PAHO for this invitation. It's an honor for me to participate from this meeting and to speak on behalf of the Brazilian Society of Family and Community Medicine. And I want to say, of course, there is no universal healthcare system if there is no strong primary health. And this won't exist without community and family medicine. And maybe these things might seem obvious, but I can say that in Brazil, we need to see the obvious every day. Because what Jacqueline addresses as a conquest, this is also a work on the position of family and community medicine and where it has to be. It cannot be seen only as a specialty. No, it's a specialty within the health system that needs to be understood as a strategy for the organization of primary healthcare, for the training of the workforce, as well as for the actual sustainability of universal systems. When we discuss the workforce, many times in our debate, we talk about numbers of professionals, but the problem is type of professionals the system's training. It recognizes and values to be able to give a response to the realities of our population. So we are a continental country, that is profoundly that has profound inequalities with complex issues. In a context like this, primary health cannot be thought as a simplified level of the system. It needs to be a place with greater clinical intelligence, a place with more responsibilities in health and more capacity for coordination of care. And of course, for that, we need specific training, and family medicine and community medicine needs to stop being seen as an appendix of the health policies and become or start to be treated as a structuring axis of the organization plan for human resources. It's not about defending a specialty because you're corporate or not, but it's recognizing evidence of universal systems need physicians that are prepared, that are ready for first contact, for full care, for the longitudinal part, coordination of care, management of complexity of everyday lives of people. And when this doesn't happen, what we're seeing is what we already know: fragmentation of care, the excess and inefficient use of resources, and the difficulty of access, and the lack of equity. The point number 2 would be the regulatory recognition of our specialty. It's not enough for community and family medicine to exist. It needs to produce consequences in the organization of the system. It's necessary for specialized training to be valued. Residency coordination should have a recognition that is concrete. We need, especially for health systems, to understand something that's basic, but not always assumed with the due clarity. Acting in primary healthcare it's not just about being an expert, a specialist in family medicine and community medicine. This is a very important point in Brazil. The specialist in family and community health still doesn't have a priority for these spots in primary healthcare, and valuing this specialty doesn't mean that we're leaving aside the non-specialist physicians that are at the front lines of the system. On the contrary, it's about recognizing that primary healthcare is complex. It demands proprietary competencies built by specific and practices that are qualified. And when the system doesn't make this differentiation, it debilitates the quality of care and the attraction of care for students. When the health system naturalizes the idea that any type of training is okay for primary health care, it sends a bad message that says that the practice and the level of attention that's responsible for strengthening the system and supporting people and doing family and community care can believe that they don't really need specialists, and this doesn't really strengthen this care. There won't be any robust, sustainable, and qualified expansion of the workforce without there being funding that is enough. It's not enough to establish generic training, but the residency and practice scenarios. And it's important to differentiate these specialists in family and community medicine through differentiated payments. We need to create working conditions and career perspectives. We need to face the challenge of professional fixation, especially in more vulnerable territories, and that are unattended. And here there is a decisive political choice. Funding can induce training, but it can also fragment even more so this system. Therefore, discussing financing of family and community medicine doesn't mean discussing professional privileges. No, it's discussing which model of a health system we are willing to fund. And finally, I want to talk about equity. Family and community medicine contributes to equity in health systems, not as a discourse, but as a concrete practice. It contributes to organizing care from where people live, because they know and face the barriers of access, because it supports people in time, because it qualifies the use of the network, because from what the fragmented models leave aside the social context and family and territorial context of the disease, suffering and care in in society is deeply unequal, and equity will not be reached, and it will depend on the adequate service with the right people, with the right training, and acting in the right place. That's exactly what family and community medicine offers. When it's taken seriously as a public policy, family and community medicine cannot act in a peripheral area outside of the central decisions of the health system. If we want to expand universal coverage that it has high quality, we need to put at the center of the discussion this matter. If we want to reduce the lack of equity, we need to put this at the center of the discussion. If we want more humane systems and more sustainable, and we need to put family medicine and community medicine at the center of the discussion. There's already evidence, the experience in Latam. We need this wouldn't be technical knowledge, it would be a political decision. And that's the most important point of this panel. And I conclude by saying that integrating family and community medicine in health systems would be a decision on the value that we're providing for the lives of people and types of systems that we want to build. Thank you so much once again for this invitation. And we continue debating here in Brazil. Thank you so much. Just a minute to close the panel and be able to continue with the program. And we're saying that the data that the study is presenting that gives us an idea of the advances and what's missing at regional level. And doing the reference of Mawini here, we're in the region of the Americas with a strong foundational tradition of the specialty in the countries of North America that is very valuable, and the wealth of the experience along the past decades in the Latin American reality in each one of the subregions. And Juan Carlos was pointing out the importance, historically recognized importance, on the prevention and promotion of health in primary health care in family and community medicine, but also in the care of people with diseases in this innovative modality of the incorporation in this day hospital of people with several pathologies that we also have to care for in these times. And then also this diversity of profiles in teaching, in research, in management, in activism that Sophia was pointing out, involved in the everyday reality of universities, of health systems, and the country in general. And closing Fabiano with what he was saying that isn't obvious, but that is also very, very important. We can't aspire to have these health systems more and more necessary in the complexity of the problems and needs of health of our populations, but also with a strong primary health, and this can only be reached with family and community medicine that is strong and recognized. And this involves economic recognition, among other things, undoubtedly. Political decisions are very important, and research should contribute to a management and governments based on recognition. Thank you so much. Thank you so much, Dr. Ponzo, for concluding this first panel. I want to thank the three panelists from Costa Rica, Peru, and Brazil. And the diversity of experiences that we just heard is a wealth. Complexity, the region. Colleagues, we're running really late. We're very interesting, but we're having problems with time. So I encourage you to try to stay within the framework of what we had planned.
About policy and systems. The second takes us into the classroom, the residency programs, and the clinics, the services, to the very heart of practice and training. Now I invite panel 2, Innovation and Future Directions, Innovation in Education and Practice Model in Family and Community Medicine, led by Dr. Erin Bokin from the University of New Mexico, who is joining us from Lyon, France. And we can invite the panelists to observe the time frame, please, colleagues. Dr. Booking, the floor is yours.
Thank you. And I'm actually going to change the format a little bit. I hope the panelists understand, in order for us to get through the material and to include everyone. I want to introduce the panelists, Carmen Cabasas, the Director of Residency Program, Pontificia Universidad de Católica del Ecuador. She's going to discuss innovations in training programs, and Ronaldo Herrera, General Secretary of the Tribunal of Medical Ethics and Deontology, Bolivia Medical College, and Ernesto Bascolo, the Unit Chief Primary Health Care and Integrated Services Delivery Health Systems for PAHO. What I'm going to ask is that that the panelists address their area of expertise with one sentence, as far as the most important contributions that can be made effectively right now to improve the practice of family medicine in the Americas. And Carmen Cabasas, if you could start off with that sentence to be how the innovation in residency models and interprofessional education can be supported.
Buenas tardes, en caso de Quito, que estoy en la mitad del mundo.
Good afternoon. In the case of Quito, we're right in the middle of the world. I'm trying to put it in presentation mode. Okay, so Erin, thanks a lot. I don't know if this would be like the last things that Fabiano said. And so we would need the political will and decision from countries to also give our best. And I'm going to comment on it on purpose in my presentation. First thing is, I have to say that I am not the director here in Quito, but I am working together in the coordination with an alumni, Dr. Vivanco, always enrolled as much as I can with family medicine, but right now as only as a associate professor. So because of time, then I used the questions suggested by the organization to be able to answer to this question brought up to me. And so the first thing I want to do is to say that in 2011, in regards to the generation of the comprehensive healthcare model, they were convinced from the government, from that political moment, that we needed to innovate in the generating and the training family physicians. And they talked about funding. Many of them before I did from the government, they allocated $80 million for family physicians provision. That's like the innovation in itself. And as Pepe Mujica said, I use my optimism. And so to me, is whether I use my optimism or pessimism for what's happening in the world. I'm going to talk about things that happened since 2013, talking about the training of family physicians in my country, which multiplied by 4 after this investment. And something very innovative that I bring about here is that it's not just, as Johanna said, talking about the classrooms. We took the university to the community, and I think that was the most innovative and the most specific. We didn't bring the doctors to the universities. We brought the university to the community. There were very few physicians, only like 300 in 2013. And that was like sort of the input, like the baseline to start with 8 universities in the country with that work in 4 provinces. With more than 20 that we are. We started with the family medicine specialization with 1 program and a very important coordination, because we needed to achieve, and we know it is clearly about the healthcare team, but we needed to have a champion of the healthcare team at a community level. That's why we decided on the training of the family doctor, and as a role, particularly in the community, with teachers in the moderating of the process. As I said, working with them on their own workplace. I'm sorry, Carmen. If you want, you can stop sharing because your presentation doesn't seem to be moving. So if you want, you let me share. Okay, I'm on the third slide. Yes, stop sharing so that I can share for you. That way we can see your presentation better.
Gracias. Qué bueno que
Thanks a
tenemos
lot.
plan B.
It's wonderful that we have our plan B. Okay, so as I was telling you, that's how we started with the 300 students, and after 9 years of training family doctors and having them graduating from the program, many of them already working with the community. We have more than 1,200 doctors, family doctors with university training, focusing on the community. And so these are the doctors that we have right now. And as what Sophia had said about how many did they have in Peru, we have about 2,000, a bit more than 2,000 right now. And the services covered by the Public Health Ministry and the Social Security service. I feel that it's changed a lot. I still am quite hopeful, although the political arena is not the best, where we don't see primary healthcare. Primary healthcare is pretty much ignored as a resource. And so I don't see right now a very good future for it. There was a historical moment, and I bring it up because it was innovative. But today we have 6 universities training medicals, training family doctors. In some universities, maybe we have like 6 students interested, but it's out of need, not actually with the intent to cover requirements per se. So as you can see, the funding, as Fabiano had said, and other speakers had said it, this was very important. So this resource created the monthly sustenance for students that had the coverage of everything. All in the university, of course, had to make money, so we were able to cover the tuition in a 3-year curriculum with 4 domains that we found that were paramount: effective communication, academic rigor, leadership and team effort, and clinical competence for the PhD resolution course. So something that really made a difference was this mentorship from the doctors that did have some experience and that were also older, and a younger family doctor as well that was being trained as a teacher himself, as a tutor, him or herself. And so this comprehensive model had an impact to be able to train a coordinator of all these networks. So all of that, thinking about the family, thinking about the community, and everything that that implies. So it's not only the consultation part, but also the care outside of the facilities, things such as the actual management, the political work being done in the various places that were going to be addressed for the training of this new family doctor, which would allow for the student or the new family doctor to remain in the actual area where he or she had been trained, to create a link with her community. So it may be complex because of the violence that the country is enduring right now. And so because of that, we are not able to go to very far places or locations.
La anterior, Johanna, porfa. No, entonces la siguiente, disculpa. Y creo que aquí
Okay, I think that with that, with
miren,
this part, I'm going to wrap up.
no, la penúltima, disculpa, Joana, disculpen todos. El escenario,
The actual scenario, the setting, and the comprehensive care model that still exists was quite outdated. It was not working with the family doctor to work properly. It was a biomedical sort of model. It's outdated because it was on the document. But today is more like a desktop utopia. Today, as Dr. Kaufman had said it, I'm also a rebel. I also complain about how the situation is right now, because this is what happened. Today, we're terrified. I don't want to stop looking ahead, but sadly, yes, we do have that document, but I have to be honest. And this model very much crashes against the right-wing perspective, looking at healthcare as a charity, as if it not being able to make it preventive, where family medicine is not strengthened because they don't see it as profitable, because it doesn't seem to go toward building hospitals and the various services for other specialties. And so in this scenario, this is the scenario where I would be a little pessimistic. And the last slide, something that also Pepe Mujica said, I've been inspired by Pepe Mujica today, but it says, defeated are those who stop fighting. We cannot go into that terrible black hole. We still have a lot of things to do. Still, just as Sophia said, maybe conditions are not as we want them to be, but we have a lot to do. And I still look toward the future in a hopeful heart.
Well, thank you so much, Carmen. I appreciate your words and your sentiment. We are going to continue on with our panel, and thank you very much again for bringing to us the idea that we should be bringing the university to the community rather than the patients to the hospital. And so I think that that's a really, oh, sorry. Thank you. And so we're going to move on to Ronaldo Herrera now with a focus on the professional development, ethics, workforce retention, policy, or governance insights. Thank you, Ronaldo.
Muy buenas tardes.
Good afternoon.
Entiendo que se me escucha
I
claramente.
understand you can hear me well.
Bien, gracias. Muy buenas tardes. Bueno,
Okay,
es
so
muy grato
good
el hecho
afternoon.
de
It's an
tantos
honor
nuestros amigos
to
y
see so
darnos
many
cuenta
friendly
que el tiempo
faces
pasa pues
and
tan raudamente
to
que
understand
ya han
that
transcurrido
time
más
is
de 20
inexorable.
años
We've already
con los
gone
que alguna
through
vez como
20
residentes
years
de medicina familiar nos habíamos conocido en la Asunción del Paraguay, por ejemplo.
reading others
Pero
that
bueno,
maybe we had studied
hablarles
with in the
yo
past,
elegí hablar
like
del modelo de
Asunción,
salud
Paraguay,
y de la
myself. I
seguridad
chose to
social en
talk
Bolivia
about Social
porque
Security in
solamente allí
Bolivia because
certificados en lo
it is
pertinente
only
pues, se ha
right
desarrollado
there is that
la
we have
medicina
found
familiar
the
boliviana
encrypted or
en 100
development
correctos
of
espacios.
family
Para poner
medicine
en
in Bolivia
contexto,
without
debo
using
decir
other
que en
spaces. And to
Bolivia hay
bring you into
tres
context, I must
subsectores de
tell
la
you
salud que son
that in Bolivia we
importantes.
have
Uno
three
es la salud
healthcare
pública, que
subsectors.
está
One is
regida por el
public
Ministerio
health,
de
which is
Salud,
ruled by the
que
Ministry
tiene
of
pues toda
Health,
una organización, un
and
sistema de
that
salud
has a
nacional.
whole organization
Luego
and a
tenemos
national
a
system.
la
Then
medicina
we have
privada, que
private
es también de
medicine,
mucha importancia, sobre
which is
todo en las
also
principales
very
ciudades.
important,
Y
particularly
luego
in the
tenemos la
most
seguridad
important
social a
cities.
corto plazo.
And then we have
Y en
Social
la
Security
seguridad
at a
social a
short
corto
term. And with
plazo
Social Security in a
es
short term,
fundamental la
it
presencia
is
de la
paramount
Caja Nacional de Salud.
to work with the presence
El
of
año
the National
1974 en Bolivia,
Healthcare
a través del
Department.
Ministerio de
In
Salud,
the 74,
pues se propone
Bolivia, through the
incorporar un
Ministry
nuevo
of Health,
modelo de
it
atención
was
en
willing
institución
to
más
create a
grande
whole new
que ese
model
entonces, que era la
that
Caja
would be of
Nacional de
more
Seguridad
institutionality,
Social,
which will be the
hoy
Social
conocida como
Security
Caja
Department,
Nacional de Salud.
known as
Y
the
en ese
National
sentido,
healthcare department today. So the idea was to create a comprehensive care that was humanized, and the concept was more and more earning space. And Bolivia was one of the countries that was integrating these first under the beliefs in 1952 with the National Revolution and with the nationalization of the mines that had been the wealth emporium of most importance that the country has had since the 20th century. So a system was designed through the National Social Security Department that had coverage in the most important cities and that would cover the most important mining centers. But from that standpoint, the truth is that was clashing against the eternal dream of having a big, fully equipped hospital with state-of-the-art technology, with the social collective example of the ideal model in the healthcare still for most of Bolivians, with the purpose to establish family medicine and the most important institution of the Social Security since 1976, when the first family doctors of the country were established with PAHO, the multiple offices in the most important cities and the most important mining centers that at that time would gather the economy and the richness of the extraction of important export minerals through the Mining Corporation of Bolivia. In that new model that provides health care to big sectors of the population, with rural and urban teachers, workers, factory workers, the blue-collar industries, and different kind of industries that cover the needs in health, and about a quarter of the Bolivian population, 3 million of people, because our country has 12 million people right now. The features of this and the model, it has to do with looking into the area, looking at the insured and the relatives, the children, a constant and comprehensive care, access subsidies for maternity, breastfeeding, with the invalidity, and the coordination with second and third levels of care. In 1977, the Bolivian Association of Family Medicine was founded to consolidate the specialty from the academic and scientific standpoint. The opening of this resident in the framework of the interinstitutional agreement is going to guarantee the training of specialized human resources, a specialty that was officially known by the Bolivian Medical College in 1982. And right now, the healthcare department is still the one that has the most presence in the development of family medicine in Bolivia through healthcare facilities of first level, known as comprehensive centers for family medicine, or CIMFACs. And another model was the team effort done by the family doctor coordinating with nursing, psychology, nutrition, social work, and some other professionals to put together multidisciplinary teams that would address people health care in a comprehensive manner, which would allow the identification of social healthcare determinants, encouraging wider and more sustainable interventions. And to there, all the purpose and everything that has been done in 50 years of presence of family medicine. However, and from that, family medicine in Bolivia, and most specifically, the National Healthcare Department faces important challenges that we describe now. First, for just a few experiences, family medicine has not reached an actual expansion outside the healthcare department, not even in other entities of Social Security at a short term. And I mentioned that the CNS has the National Healthcare Department, which has an important power of decision that has the most support by the workers' centrals in Bolivia, which is engaging into a lot of decision making that needs capabilities and technical training, and they don't come at the same level. And then at a better level, direct allocations are given to professionals and politicians that are people that have not actually developed an educational road, but more than the influence to be in their political position. So all of this, known as social control, has the predominance of the hospital model, the construction of complex structure and facilities, and a lot of specialists under the concept of someone who has an influence in healthcare levels, living and as underestimated the promotion, education, and specific protection. That growth has not been considered in the proper way, which has caused the collapse of these family medicine centers that are working at a level of 15 minutes per patient, which establishes, first of all, the impossibility, the obvious impossibility of the methodical use of instruments of family medicine, just as familograms and other instruments of the specialty. The difficulty for them to have an actual appointment, because that is a limit of medications established, adding to it, and the identification, dyslipidemia, and as tuberculosis, which is still present in the country, because it makes it more difficult to have a timely intervention in pro of healthcare.
We see that minutes that we've had are insufficient, but as a final proposal, I think it's necessary to integrate a new model that integrates information and communication technology, digital health, but that at the same time reivindicates the physician-patient relationship towards the family and the community. I thank you for your attention.
Thank you so much, Rolando. Thank you so much, Rolando, for those very, very keen insights into your country and into the professional development of family medicine there, along with the policy and governance of that country over the years. Thank you so much. And now we're going to move on to Ernesto Bascola, from PAHO, and he's going to focus on the primary healthcare policy, integrated service delivery, and regional models with sites on future directions.
Thank you very much. Thank you very much. Bueno, colegas, muchas gracias por la invitación.
Okay, colleagues, thank you so much for your invitation to this beautiful webinar. I'm going to try to do my best to meet with my 8 minutes. I tried to coordinate policies of primary health care and primary care-based systems. And I loved hearing about the weight of primary care in your speech, even with this view on integrated networks on health services. And I want to emphasize here simply that within the framework that we have in our health department systems, the health services provision is a fundamental role, and it means a comprehensive view that is integrated of individual and collective services with intersectoral interventions, but the component of human resources has a decisive weight, not just in healthcare provision, but also in the rest of the functions of the system. And when I say this, I want to emphasize, because it's not the only role to generate resources. The most important resource, not just for the health system to work, but also to transform the health system, and I'm paraphrasing a lot of your expressions, has to do with human resources and family medicine, of course, is an indispensable stakeholder within this process. I wanted to emphasize on the fact that resource generation, even if it includes aspects like technology, infrastructure, information systems, the human resources component is key in the aspects of regulation and policy, and the aspects, I'd say, not just institutional in that enable the provision of services, but also have an intersectoral component that's very large. And this leads me to one of the most important challenges that we have in the Department of Systems and also in my unit of primary care. And it's that if there's something that appears easily as a consensus that is easy to build among many stakeholders in many countries are primary healthcare policies. 86% of the countries in our region have primary care policies. However, less than 1/3 have capacities and structures and resources enough to implement it. A lot of this is related to human resources, and I'd love to tell you about this with an element that is cross-cutting to us, which is the analysis on the essential role of public health. I don't know if everybody is aware, but rule number 6 is the one that is linked to human resources, and there's two aspects that I would like to highlight and that are weaknesses of our country in the exercise of essential functions in public health. And this is the result of a publication of 2024, 14 countries where we implemented at national and subnational level this exercise. And if a weakness is important to highlight, once again, is the subnational capacities to manage access to health services. And the other element that I think is transcendental are the very important weaknesses in terms of roles associated to regulation and planning and allocation and the definition of the profile of human resources that we need to strengthen a perspective on primary health care. I used to mention that I was saying that there's resources that are critical to enable a primary healthcare policy, and I was mentioning infrastructure, information systems, and medicine. And precisely these three elements are crucial and are prioritized in the governance of the implementation of primary health policies, healthcare policies. And I want to show the other extreme, and it's that what has the least prioritization is the community participation in the governance at territory level, and it's an intersectoral way of addressing things. But what I would also like to highlight is the low priority on the incorporation of human resources as a fundamental resource at subnational level to manage these capacities that I previously mentioned. And this is related to the concept of governance of the health system, but especially on human resources governance, way below the rest of the resources that do have a greater priority, as I was mentioning before, infrastructure, information systems, and medicine. And these difficulties to incorporate the human resources agenda within an agenda to strengthen a health system with the primary health care perspective is also seen when we analyze the difficulties in terms of coordinating health policies by health authorities with key stakeholders that as universities, professional institutions would have to be a part or should be a part of. As part of this exercise of essential roles or functions, we mapped stakeholders, keeping in mind each one of the essential roles. And I selected human resources here very clearly. What we have here in orange is related to institutions that are fundamental state institutions, civil society, or private institutions, where we can recognize that there's not just a low alignment in regards to the mission or the competencies of said institutions to strengthen human resources policies aligned with primary healthcare, but also the effective capacity to have influence by the authorities. Another one of the points that, of course, when we ground on the organization model of the services and we recognize that clinical guidelines and pathways linked to, like, there's many cases with infectious problems, not just that, but also non-communicable diseases. We see that not many more, 62% of the countries that we've analyzed have these types of guidelines. A lower percentage, 56%, there's workers that are trained explicitly to receive this kind of guideline, and we're talking about half of the cases in our countries. Now, when we analyze adherence and compliance with these guidelines, the numbers are significantly reduced, reaching 13%. And this indicates that there's high consensus to have primary healthcare policies. We have a good conception on how health services should be organized with a network's perspective, with care guidelines, but there's been a lot of difficulties when guaranteeing a very important role on part of workers in the implementation and adherence to these guidelines. Another good example is when we analyze the countries that have multidisciplinary teams that are already established, and we're talking about 50% of the cases of the countries that we've analyzed. Now, when we analyze if in these cases there's composition and competency and the set of skills that are needed, the numbers significantly drop to 9, 22, or 17%.
To conclude, we had like a capital, like something that we want to strengthen that has to do with policies that are aligned to universal health, with APS policies that reached out a high consensus and with a very specific role of human resources. That is a capital, just as you said, something that needs to be strengthened. It's a legitimacy that it has earned, but at the same time, we're also facing an important gap in terms of skills that we need to work with a lot, both in the priority to human resources, the spaces for management, governance, the networks in healthcare services, kind of a progress, and it was something that we needed to do in terms of multidisciplinary teams with not sufficient preparation and skills and capabilities. We've had national and subnational needs for training it to cover the territory with these elements that we repeated as a mantra and that is completely important, which is a comprehensive integrated access to guarantee access to care. Thank you very much.
Thank you very much, Ernesto, for all of those very innovative ideas in relationship to service delivery and family medicine in the Americas. And I'm going to pass it back over to you, Johanna. Thank you very much.
Thank you very much, Erin. Gracias por esta excelente moderación.
Thanks a lot for this wonderful moderation, Erin, colleagues, Dr. Carmen, Dr. Rolando, Dr. Vascola. We thank you so much for your participation, and we've reached the end of our webinar. We've gone beyond our time, but I want to thank all of you who have been there for us, and we still have more than 170 people all together with us. Thank you so much. And I think we've made it to the end with a lot more information than the one we had when we just arrived, but certainly with a lot more questions than when we started. And that's exactly what should happen when there's a genuine conversation on something so important.
James Fitzgerald, the director of the Department of Health Systems and Services at PAHO, to share the closing remarks for this seminar. Dr. Fitzgerald, the floor is yours.
Thank you so much, Johanna. A very good afternoon to you all. My heartfelt congratulations to WONCA, to the University of New Mexico, and of course to our own team here at PAHO for really an excellent publication. The generation of really important evidence and data that will guide us in the development of health policy and workforce policy in the future. And of course, to all the speakers and participants in the panels that have really showed us the depth of knowledge there is in the region of the Americas on such an important issue, and then the linkages that exist between this issue in terms of the provision of care in the community with policies, regulations, systems organization, and other inputs that are required to make sure it happens. A couple of highlights, I think, for me as we close this event. Numbers are important in the sense that we see a significant, I suppose, underproduction of specialities in family and community medicine, and in particular in primary health care. But as was so well highlighted, I think also this is just one element. I think it was Fabiano that mentioned that this goes well beyond the issue of the production of health workers, but in terms also of the quality and the frameworks that need to be really put in place as we move forward. And so we will continue to work as an organization, not just on supporting countries in the development of workforce planning processes in health workforce policy, but also particularly in increasing the production and generation of family and community medicine specialists that will constitute a key pillar within interprofessional teams, within integrated health services networks within the region. My second and final point is that this is a start. This is a baseline study. This has been really important for us to do this work over the past few years with WONCA, with the University of New Mexico, to establish that baseline, to see therefore how we move forward, the decisions we take, the recommendations that Benjamin produce, what impact will they have as potentially we repeat this work in 2, 4, 10 years, and to see how the region moves forward in really increasing its capacity to generate the necessary specializations that's required in family and community medicine, and in particular in primary healthcare. So once again, my congratulations, my thanks to you all. This is a very exciting study. It's the beginning of an important piece of work, I think, for the organization moving forward. And we really look forward to continuing this work with our colleagues, with all the collaborators here, and of course, with all the countries that are connected. Thank you. Thank you very much.
Thank you very much, Dr. Fitzgerald. Colegas, muchísimas gracias a cada
So colleagues, thank you so much, everybody. Thank you to all, to our panelists, our moderators, our experts, colleagues from ministries, scientific societies and associations, to all of you. I know that we were able to reach about 200 participants, and even with this time that we have, we still have an important number of people. We thank you for your engagement and participation. Just as Dr. Fitzgerald said, this is one step toward a better systems of healthcare where community and family healthcare can cover this strategic place that it's supposed to cover. And we really want to encourage you to look into the original paper that was published on our website and to stay connected with all of our activities. And we close this activity with thanks to the technical team and our interpreters who have been running and been there with us all the way to the end. Thank you all so very much and have a wonderful rest of day. Goodbye.